My name's Suzy Braye, and I've been a social worker for much of my career, working in the local authority context, social worker and social work manager. But I spent the latter part of my career in the university sector, in social work education and social work research. And it's that capacity that I got very interested, very involved in adult safeguarding, both teaching and also learning about how adult safeguarding practice has developed in practice. And back in 2010, 2011, colleagues Mike Preston-Shute from the University of Bedfordshire, David Orr from Sussex, and I were involved in some research on self-neglect, specifically for the Department of Health, and specifically to inform the development of the Care Act. And it's during the subsequent few years that we got very interested in what serious case reviews, and subsequently now called safeguarding adults reviews, can tell us about what goes wrong in self-neglect specifically, and in adult safeguarding more generally. I'll tell you a little bit more about that research in a moment. I now practice independently, having taken retirement from the university as an independent safeguarding adults consultant, and in that capacity I do conduct safeguarding adults reviews. So a lot of the examples I'm going to use today are cases that I know personally because I've been involved as the independent review writer in a safeguarding adults review. Too warm, by the way. We've closed the door for now, but if it gets too warm, do say, and we'll open it again and get a little bit of fresh air into the room. So, just to set out the basics, really, you'll be aware that the Care Act 2014, implemented in 2015 in April, set out a statutory duty, gave safeguarding adults boards a statutory duty to review serious cases. And a case in which a review must be commissioned are cases in which an adult has died as a result of abuse or neglect, or been seriously injured as a result of abuse or neglect, and where there is some concern about how agencies might have worked together to help and support and protect that adult. The purpose, of course, is not to allocate blame, although, of course, going through a safeguarding adults review and having your practice scrutinised is quite an uncomfortable and difficult process, both for individuals involved and for agencies. And these are often sad and tragic stories where the distress has been shared, really, amongst a professional network. But the focus really is on learning. It's how can we extract learning from what happened in order to apply that learning to future cases, in order to prevent future circumstances, similar circumstances arising. And that fits very closely with the Safeguarding Adults Board statutory duty to facilitate working together in adult safeguarding and to bring about quality improvements in adult safeguarding in its given area. So a safeguarding adults review typically will seek information from all the agencies that were involved in the case where the adult has died or been seriously injured. We'll establish a series of chronologies that enable us to piece the story together. We will find out what happened, but then we will ask for reflection and involvement in thinking together between the agencies and those involved on why what happened and what we can extract from that. Essentially, what we're looking to do is to achieve whole system understanding. Yes, in the Safeguarding Adults review, there's a lot of focus on this initial layer, the adult at the centre of the concern, and the direct practice, the way in which practitioners who were face-to-face and working directly with that adult practiced in that situation. But very often, when we look at what happened in a situation, we're not it's rarely something that is attributable entirely to an individual practitioner or entirely to what happened in direct practice. If we ask the question of why did the story unfold in the way that it unfolded, we often see that there are features within organisations that impact, sometimes in a way that hinders direct practice with the adult. We see that there are ways in which agencies work together that hinder interagency collaboration in a serious case. We see sometimes that the interagency governance exercised by the Safeguarding Adults Board has gaps within how it guides and shapes practice in a given locality. And of course, that situation has always arisen within a particular legal and policy context, which sometimes helps and supports practice, and sometimes, frankly, is less of a help and can hinder. Some of the shortcomings, for example, in the Mental Capacity Act that I know Alex was talking about this morning, and some of the proposals for change there, we see evidence of that also in Safeguarding Adults reviews. So essentially what we're looking for is whole system understanding, and we often differentiate between a system that is safe and a system that is unsafe. You'll be familiar perhaps with the Swiss cheese model of looking at the effectiveness of a system. If you think on the left-hand diagram of that back layer at the back there as being the work of an individual practitioner, and then the other layers being perhaps the management and supervision that person receives, the interagency scrutiny that that agency's practice receives, you'll see that if there's something going wrong in direct practice, but management supervision is strong, then that will be picked up and deflected. So the impact of what's going wrong in practice will not reverberate through the whole system. Equally, if something's going wrong in practice and possibly it's not picked up by supervision and management, so it travels through those two back layers, if it bumps into then a strong and robust interagency governance system, visibility between agencies about what they're doing, then again the error can be deflected and remedied. But it's where the gaps in the system line up, we get the holes in the Swiss cheese lining up, that we see developing what in effect is like a fault line that runs through a case. And typically within a Safeguarding Adults review, we can see, going back to this diagram, that there is a fault line that runs all the way through from direct practice right up to board governance mechanisms. So if we ask the question why, we often get access to answers that enable us to think what system changes need to happen to prevent things going wrong again. So just to mention very briefly the studies, what I'm going to draw on today are 3 studies in fact, 2 of which are mentioned here, and one of which, the third, isn't, but which I'll tell you about first. Back in 2014, we, as part of another piece of work, we got very interested in what goes wrong in serious cases, in self-neglect in particular, because that was the focus of our research at the time. And we began to look at and read Safeguarding Adults reviews that were published, or where executive summaries were published, or where we were sent information from boards because people knew that we were interested in tracking the themes that were developing. So we began to look for common themes across self-neglect Safeguarding Adults reviews. And we've continued that work. And you may or may not be surprised to know that there are now upwards of 180 Safeguarding Adults reviews in which self-neglect is implicated. That's a vast body of learning. But what's interesting about it is that we see a relatively limited number of common themes emerging, and that's partly what I'm going to talk to you about today and give you some examples from some of those self-neglect Safeguarding Adults reviews. Subsequently, we, or as part of the same initiative, we've done 2 further studies across all categories of abuse and neglect. So in 2017, the London Association of Directors of Adult Social Services, London ADAS, asked us to take a look at all the SARs that had been completed in London boroughs since implementation of the Care Act on 1st of April 2015. So we were looking at two years worth of SARs, and we looked in effect at 27 SARs across all categories of abuse and neglect, including self-neglect, but other forms of abuse and neglect also. And then on the back of that, the southwest region of the Association of Directors of Adult Social Services came back and asked my colleague Mike Preston-Shute to undertake a review of all SARs published in the southwest of England since implementation of the Care Act. So Michael looked at a further 11 safeguarding adults reviews in the South West. So that body of learning comes into our general understanding of what's emerging from SARS. And particularly focusing in those studies on what the learning does to help us understand what goes wrong in serious cases and how that can inform changes that boards can take account of, even if they haven't themselves experienced a safeguarding adults review, which of course is the case in Bromley. Until very recently, there hadn't been a safeguarding adults review here. So that's the material, if you like, that I'm drawing on, and I'm going to today talk about, going back to that systems diagram, 3 of the key domains of learning. So the learning falls into one of 4 categories. Often we see learning about direct practice, about how we interact with an individual. We see learning about what organisations do that help and hinder good practice in direct work. We have learning about interagency cooperation and how agencies work together. We also get learning about how the Safeguarding Adults Board exercises its governance mechanism, its policies and procedures, its quality monitoring, its audits, its development work with agencies. But we've got to be sensible about what we can achieve in a short space of time this afternoon. So I'm going to, through the next 3 slides, take you through some of the themes emerging from those 3 domains. Give you a few examples insofar as we have time to do that. So the next 3 slides are really the heart of the learning from Safeguarding Adults Reviews, presented thematically. So if we look at direct work, these are the themes that emerge, not necessarily in any order of priority, but it's true to say that risk assessment is key learning that emerges often from a SAR. We don't worry enough about a situation. We don't think hard enough about what we might need to do to mitigate risk, and sometimes that's because we haven't done a holistic risk assessment that's been shared across all the agencies. Just as a brief example, a SAR published on the City and Hackney Safeguarding Adults Board website that I was in fact involved in writing, the situation of Miss Q. Miss Q died in hospital on what was her 7th or 8th admission to hospital in the space of a year. She had COPD, she was extremely frail, her body mass index was around 12. She was severely neglectful of herself in terms of eating and drinking, and she smoked. There was some hoarding in her property. And she died, in fact, of pneumonia, having been admitted to hospital for the 7th or 8th time. Now, when we look back at that period of a year when she'd been on this revolving door in and out of hospital, what we found was that on each admission, the medical input was very strong, her health conditions, health concerns were addressed, and there was concern about giving her support when she was discharged, but she consistently said, no, I don't want anything, thank you, my daughter helps me, and I don't want any services. And the risk assessment kind of stopped there, and you might understand that that could stop there on the 1st or 2nd or 3rd opportunity, but on the 7th opportunity to piece together a mounting situation of risk and to ask questions about, well, what is happening when she's at home, those opportunities seemed to be missed. Such that there was never a home assessment. The occupational therapist and the social worker assessing her in hospital or attempting to assess her in hospital didn't make any home visits, didn't see her in her home environment. So we knew very little about how she was living at home and very little about the circumstances that were resulting then in her having to be readmitted back to hospital, often in an emergency by the ambulance service. So, risk assessment, common theme. The next 3 are really a cluster of related themes. We're not persistent enough in trying to seek somebody's engagement. If somebody, particularly somebody who's self-neglectful, people are often very reluctant to engage with support. It takes a long time, we know that from the research findings, to engage with somebody, to build a relationship. You're often doing that on the doorstep for a considerable number of weeks before you can establish a degree of trust that will enable you to get to understand the individual. And we don't do that. We don't persist in that for all sorts of reasons, some of which are organisational, of course, and I'll come back to that. And as a result of that, sometimes our responses to service refusal are fairly basic. Well, the individual doesn't want anything, therefore we're going to walk away. And there are lots of incentives for doing that in terms of the weight of caseload waiting, new cases, new assessments to be made. Why spend a lot of time questioning somebody's refusal when it appears that they know what they want? So the learning is that we tend to overemphasize lifestyle choice. We tend to make assumptions that somebody living in dire circumstances, some self-neglectful circumstances, are extremely squalid and extremely risky and dangerous, is doing so because they're making a lifestyle choice and that they have a right to do that. So we're not really digging underneath that and trying to understand whether that really is a choice. And what we know from the self-neglect research, which I don't have time to talk about today, is that it's quite unlikely to be a lifestyle choice. It's probably a source of considerable distress, considerable shame, and considerable fear. And it's those emotions that create the barriers that we need to work with slowly and carefully. So what we see sometimes is that making safeguarding personal is applied in a fairly simplistic way. In the cases that go wrong, we've often seen reference to phrases such as, well, you know, we had to respect her wishes and feelings, so, you know, and that's what making safeguarding personal is about, isn't it? It's an oversimplification of MSP, which in a more complex version of the concept is really about working closely with an individual to identify what outcomes they might be seeking in their life, and to work with them to build the trust to enable you to help them, or for them to allow you to help them to realise some of those options. But there's an awful lot of barrier to work through before you get there. So application, simplistic application of MSP. And we saw that in another case, the case of Mr. A, which is an East Sussex case published on the SAB website. Mr. A was a resident in a nursing home. He had Korsakoff syndrome. He had long-term damage from lifelong drinking. He also had extremely problematic skin breakdown as a result of other complex health conditions. So he had leg ulcers that needed constant care, nursing care. He consistently refused that care, and the nursing staff, by and large, although they tried to persuade him to accept the care, they didn't really challenge or get to grips with what was underneath, what was driving his refusal. And his situation deteriorated horrendously. He was at very high risk. He would walk around the care home because of the nursing home. He was relatively mobile, and there would be maggots dropping from his legs onto the floor. But again, that fed into risk assessment, no holistic risk assessment that really looked at the overall consequences of this, or of the impact on other residents and staff, of course. So a number of things that were problematic there. But in terms of MSP, what the nursing staff thought they were doing was the right thing in terms of observing his wishes and feelings and placing his wishes and feelings at the centre of what they were doing. Further complication in his case was that he'd actually been assessed as lacking capacity to make decisions about his living situation and his care and support. But he was treated as if he did have capacity, and there was no best interest strategy about how, given that he lacks capacity to make these decisions, how in his best interest are we going to deliver the care and support. So MSP was really the overarching handle, if you like, the overarching feature of professionals, of the care staff and nursing staff during that case. Mental capacity is another key theme. We're afraid that what SARS tell us, by and large, and many of them do, well over half of safeguarding adults refuse tell us, is that we don't do mental capacity assessments sometimes at all, certainly not frequently enough, and when we do them, we don't do them well enough in a way that accounts for the complexity decision-making, particularly in self-neglect cases. There is lots of evidence of an absence. I mean, Mr. A himself in the nursing home is evidence of, in fact, having not updated and not played through the elements of mental capacity. So there was one best interest meeting that didn't result in a strategy, and subsequently no further roundtable discussion of what was in his best interest. But we see absence of mental capacity assessment, or we see reliance on an assessment that was perhaps done 3 or 4 years ago, possibly by somebody influential, often mental health services or a psychiatrist, and that assessment or finding of capacity then gets written as if it's on a tablet of stone and gets translated and shared across all the agencies. So in a number of cases we see a significant capacity assessment that then is never repeated, even though it's not clear from the records in relation to which decision that capacity assessment was made, when it was made, who made it. It's certainly not been updated, it certainly hasn't taken account of fluctuating capacity. So we sometimes don't do capacity assessments, we certainly don't record them well enough. But when we do, some of these evidence from Safeguarding Adults reviews shows us that we don't take account of all the possible circumstances. The self-neglect literature tells us that influential often in whether we make self-care decisions is whether we are able to understand, retain, use and weigh relevant information, not only in the abstract when we're sitting down and talking to a practitioner, but whether we're able to do those things in the moment when we're making a decision. So for example, I'll give you another example, Mr. BC, City and Hackney case again, when Mr. BC died in a fire. He was in his 70s, he was relatively immobile, lived in sheltered accommodation, but he was a smoker and a drinker, and there were a lot of concerns about his safety, but also the safety of other residents. But a capacity assessment, despite a number of safeguarding alerts that unfolded over a number of years about the risks, a capacity assessment wasn't done until very shortly before he died, when there was a move to think about whether he should be living in more supported accommodation than he was in his sheltered accommodation. So the social worker did a capacity assessment, but didn't bring in information that in fact would have been highly relevant about his ability to keep himself safe in the moment when he was smoking and drinking. So although he could give quite a good account of, no, I want to stay where I'm living, I don't want to move, thank you very much, there was no consideration given to information that in fact the GP had from the hospital where he'd been previously admitted, who had expressed concerns about the impact on his decision making of a series of strokes that he'd had. And the view was, in medical records, that it may be that he lacked executive capacity, the ability to understand, retain, use and weigh information in the moment when you need to problem solve or take action to keep yourself safe. So that information never got through into the capacity assessment. So this is a very common picture that we're seeing from Safeguarding Adults reviews. Other themes, just to move quickly on, we're not finding enough out about people. Professional curiosity, understanding why the individual is behaving or living in the way that they are behaving or living. If we think back to Ms. Q with the rotating door admissions to hospital, what we found out was that she had quite a traumatic past history, a difficult family history that involved suicide by her husband and estrangement from at least one of her daughters. But this information didn't really seem to be taken into account in thinking about why might she be refusing care, why might she not want help and support at home, why might she not be eating and drinking but relying on cigarettes to suppress her appetite. What's the meaning of the hoarding or the clutter around her home? We don't spend enough time understanding the history and the meaning of the behaviour that we're worried about. We go straight for problem-solving interventions that can contain or stop the behaviour, rather than trying to understand it. And what we see from the self-neglect research is that behind much self-neglect, and potentially around other forms of abuse and neglect also, are often traumatic life histories, distress, difficult circumstances, loss, bereavement, abuse. We need all of that picture to be making effective interventions. And equally, we don't think family enough. We don't think what's the impact of the family dynamics that are going on here. Just one other quick example, Ms. Y. This was a case where Ms. Y was living with her two daughters, in fact. The house was very dilapidated, lots of overgrown things, lots of accumulation of household waste outside. So lots of attention from agencies, lots of people walking up the garden path to see what was needed. There were concerns about her health also. It was known that she needed, again, care for skin breakdown on her legs, but very often the community nurses, the district nurses, were turned away. And the consistent picture was that the door was opened by one of the daughters who said, "No, it's fine, Mum doesn't need anything, she's absolutely fine, she can do it herself, we can help her." It took some time for what to emerge as a knowledge that, in fact, a visit by the police were doing a welfare check to identify her. They did see her, and she told them that her daughters locked her in a room and were denying her access to the community nurses. So there was a very different picture emerging. Unfortunately, the police didn't refer that into safeguarding, so it wasn't pursued as a safeguarding issue. So again, thinking family, thinking about the influence often of adult children who are living with or close to somebody, but often of dynamics between a couple also. One example of a man who needed medication in order to stay well, but he consistently refused it. He appeared to be self-neglectful, but in fact what emerged was that in fact it was his wife who was saying, "No, don't take that stuff, it's bad stuff, it'll harm you." And that was arising from her own perceptions and needs and perspectives, rather than his decision, but she was influencing his decision to self-neglect. And sometimes we see that there are just sometimes poor service standards. We see problems with frequency of visits, care staff who miss visits, community nurses who miss visits, and not necessarily because they wish to, but because organisational systems issues prevent them from making a visit at a particular point in time. So that's the learning, and the more detail there is useful, I think, but partly because of the theme of the conference, which is about the individual and focusing on the individual. But we do also need to trace back and look at the organisational factors. What we see are that sometimes, if we ask the question why do these things happen, we see sometimes that people haven't had training, or that people haven't had procedural guidance. We see that managerial oversight hasn't been exercised. Back to her rotating door in and out of hospital. Each time she was discharged, having refused a care and support package, the case was closed. And in fact, there was no sign-off of that. There was no management scrutiny of that. So there was no double check on the decision to close the case. We see an absence often of legal literacy, sometimes within an organisation, a lack of knowledge about what powers and duties could be exercised by our own organisation. We see too, I have to say on the next slide, misunderstandings about what other organisations can do legally as well. But legal literacy as a way of approaching the case, what are our legal powers and duties here, doesn't seem to be as embedded when things go wrong as it should be. We don't escalate risk. Some organisations have a culture where you just manage the work and risk management remains at team level. Mr. BC, the man who died in the fire, that was an extremely high-risk situation. But about him, it had been said by the fire brigade, this is not a question of if a fire occurs, it's a question of when it's going to occur. But that information wasn't escalated up through the organisation in a way that could have enabled managers to exercise their responsibilities to secure safe practice and safe risk management. Workflow practices. By this, in adult social care, we mean care management, but in other organisations, expectations of care pathways where you have relatively short-term time limit involvement with somebody. You move through assessment, eligibility, care package, commissioning of care and support, and then often the case is closed. So there isn't a continuity of involvement. That really militates against getting to know the person and being able to spot subtle changes in capacity, for example. So workflow practices, performance management that really constrain how long people can spend with clients and patients. Recording practice, IT systems that don't talk to each other. Very common in a case involving health risk. The systems will be different. The GP will have one system, community matron will have another, community nurses will have another, the hospital will have another. And that's before we even move outside of health into adult social care. IT systems that don't talk to each other, a lack of common information that makes information sharing even more crucial than it would otherwise be. We see resource challenges, lack of staffing, low staffing, and sometimes a lack of placements. Mr. A, the man in the nursing home who was refusing care for his legs, he was placed in that nursing home because there wasn't a really suitable placement. Commissioning in the authority that placed him hadn't been able to source a totally suitable placement for him. So that SAR made a lot of recommendations back to commissioning about real gaps in commissioning of care and nursing care. Agency cultures, again, that can close down professional curiosity. If I ask a practitioner, well, you know, what lay behind your decision not to pursue that information with that person, not to spend a bit more time learning about their life history? And an answer might come back to the effect, well, you know, I can't really do that because if I do that, then I'm going to keep the case open too long, and you know, I won't be able then to meet my targets in relation to turnover of cases. Quality assurance and contract monitoring. We don't necessarily, we're not necessarily hands-on enough in cases that go wrong. We haven't been hands-on enough in terms of monitoring the quality sometimes of care providers, and we haven't escalated those concerns if we have them. And often we don't have a means of tracking cumulative risks. So in relation to Mr. BC, the man who died in the house fire, the smoker and drinker, there have been, I think there were 9 safeguarding alerts, but each safeguarding alert was responded to as if it was the only one. And at no point was the suggestion, well, there have been 9 now. What does that mean? What does 9 add up to? How many oranges, in terms of alert response, does it take to make a red? The same with Ms. Q, with her 7 admissions to hospital, each dealt with as if it was the only one. How many oranges does it take to make a red? And then finally, the third domain, the findings in relation to interagency cooperation. It's very common. In fact, the 2 most common findings from Safeguarding Adults reviews are the absence of mental capacity, or the quality of mental capacity assessments, and the absence of case coordination. So we see a lot of silo working. Mr. BC, the man in the fire death, he had lots and lots of support. 3 times a day, 7 days a week support package from adult social care. A very hands-on warden who saw him several times a day. A quite involved family who came once a week. A GP who was very attentive, did lots of home visits. He had blue light services as well. If he fell and needed attention, the ambulance service would come and pick him up, take him to hospital. The fire brigade came and did home fire safety visits to look at fire safety. And he wasn't the only person who liked to drink in his sheltered housing complex. He had a drinking buddy, and when they had too much to drink together, things got aggressive and they had fights, the police would be called. So he had lots and lots of attention, but the problem was nobody was talking to each other. There was a lack of communication across the board. failures of information sharing, and a lack of leadership, really. Nobody in that role of saying, you know, I'm coordinating and getting information from all the different sources so that I can create an overview, a holistic perspective on what's happening here. We sometimes see an absence of challenging each other. In another case I've not talked about, a man who was having a lot of 4 times a day care worker visits, and also twice a week community nursing for attention to his legs and to pressure sores elsewhere on his body because he was relatively immobile. There was sometimes long gaps between the visits by the community nursing team. And those gaps were visible to the sheltered housing warden, they were visible to the care workers. But there wasn't always the escalation back, the question back, what's happening here? Why are we not seeing the service being provided? An absence of safeguarding literacy, self-neglect in particular, is often still not seen as abuse and neglect that falls within the umbrella of the Care Act statutory guidance, which of course it does and it should. So whenever we think abuse and neglect, we should bracket including self-neglect. We see very high risk concerns about self-neglect that are not then fed into safeguarding. So we don't have access to that complex and often very well oiled and effective safeguarding multi-agency strategy meeting and case conferencing system. Absence of legal literacy, even if we know our own agency's powers and duties, we might have quite a different perspective on what other agencies can do, and not always an accurate perspective. And that sometimes lies underneath disputes between agencies about who should be doing what. It's common in serious cases to see that agencies have never sat down together to say who can do what here, and in what order should we be thinking about doing it. And then sometimes it's what one coroner has called the collective omission of the mundane and the obvious. This is back to the man who died in the fire in his flat. Again, with all of those parallel lines of agency involvement, the coroner was very exercised to work out and to find why he didn't have a smoke detector in his bedroom when he was known to smoke and to drink in his bed routinely, and indeed the seat of the fire that killed him was in his bed. He had smoke detectors, I think 2 smoke detectors in other areas of his flat, but none in the bedroom. And the coroner was very exercised by this, and very keen to know how so many agencies doing such good work on their own terms had collectively missed this very, what she called, mundane and obvious point, because it was nobody's job to do it. He was a householder. It was nobody's job to say, we need to fit the smoke alarms here. So, a number of learning points from the SARS. I'm going to take a short break and ask you to have some discussion together. It's going to be slightly difficult in the context of this room, but it might just be a question of turning to the person or the people next to you, 2s, 3s, 4s, whatever works in the context of the rows that you're sitting in. And I'd like you to do 2 things really. One is to ask yourselves the question, could it happen here? These things that these themes, these learning themes that we've identified, could any of this happen here in Bromley? And if so, if not, why not? What are the strengths of your local systems? If you think it could happen, what are the fault lines? What are the things that need to be rectified? What do you need to give attention to in a preventive sense? So how can in Bromley you learn from the thematic learning from SARS in other agencies? I'll just give you, probably less than 10 minutes, so work quickly. We don't have a lot of time, but it just gives you a chance to think about the local context. We don't have time to take detailed feedback from your discussion, but I'd like to ask you to answer the first question. Could it happen here?
Yes.
So that then leads us, and I hope one of the takeaway things from the workshop for you will be to go away and think in more detail about the strengths and weaknesses discussion that you were beginning to have there. What are the things that could prevent it happening? How can we strengthen those? And what are the weaknesses? What are the fault lines? What are the holes in the Swiss cheese through which errors can fall? And within your individual agencies, you may well be able to have discussions and take action to close some of those holes. But it's also a matter for the Safeguarding Adults Board to think about how, in its overarching role of facilitating joint working, how it can support through the development of policies, procedures, protocols, guidelines, support, work with agencies to put in those preventive markers. But just to finish off then, hopefully in time to get you back for the plenary, the next 3 slides, we won't go through them in detail, but essentially they are the reverse of what we've been talking about. They are the good practice indicators. We learn about what goes wrong in SARS, and that gives us indicators about what to do differently. So these 3 slides are things that we need to be doing differently in safeguarding. And in direct practice, it's really about emphasising the individual, finding the individual. The user focusedness that is embedded in the theme of your conference here today. It's about a focus on their family actions. It's about robust risk assessment, mental capacity assessment, being proactive in the face of apparent lifestyle choice and service refusal. Asking what one respondent in our research, our self-neglect research, called carefrontational questions, holding up a mirror to people that reflect back their understanding of risk and the element of beginning to think about different options that they might have and they might be making. That maybe their distress and trauma, their fear and shame is closing down for them. Balancing those moral dilemmas, respect for autonomy with protection. We're often very quick to say people have a right to autonomy, and of course they do. There are lots of good reasons why they do. But we also have a duty of care that sometimes leads us down a protection path. And thinking not just on what I'm doing in my organisation with this individual, but what are other organisations doing? Who else needs to know what I'm doing? How can I communicate across those agency boundaries? And at organisational level, it's about how organisations can support staff to practice in that way. How can we strengthen staff support and supervision? Working with self-neglect, and in fact all forms of abuse neglect, is hugely distressing and challenging for practitioners. You don't need me to be telling you that. It's how can we respond to that and support people in the context of management and supervision to be resilient in the face of sometimes quite challenging and distressing circumstances. It's also about changing organisational culture so that we do encourage escalation of risk. We encourage bad news to filter upwards through the organisation, because that's what alerts management to the need to take action. Workflow that permits longer term engagement. Not in each and every case, of course that's going to be totally unrealistic in today's circumstances, but in a smaller chosen number of high risk, very complex cases. Flexibility to move outside of the expectation of time-limited workflow, and full consideration of legal options both within the organisation and across organisations. Even if you decide not to work under any kind of legal power that gives you a power to impose a solution, but just mapping out what can be done and what would be the triggers for each of those. What might be the trigger for best interest decision making? What might be the trigger for deprivation of liberty? What might be the trigger for mental health assessment? What might be the trigger if you've worked through care and support assessment and mental capacity act assessment? What might be the trigger for then moving into more imposed solutions under environmental health legislation, under antisocial behaviour legislation, under animal welfare legislation or housing legislation? The legal options in effect line up in an order, and we need to work through those, but understand what the whole picture might look like. And then at interagency level, the real priority has to be about how we coordinate complex networks in the context of a high-risk complex case, so that we can move beyond the silo working that is so characteristic, and make sure that each agency's role is clear, but also that there is a coordinating person offering some leadership and coordination to a network in very high-risk cases, particularly apparent in self-neglect. And thinking about how we can give attention to key transition points. I mean, back to Ms. Q, her hospital admission and discharge process. Those hospital discharges are often a key transition point where we can put in a different approach that enables some continuity of care to go out into the community. So, good practice indicators, some key takeaway messages. And I wanted to end just by going back to the user-focused approach and just reminding us of the focus on the individual. We talked in our self-neglect, one of our pieces of self-neglect research, to 29 service users, and we asked them what had worked for them. These were service users who were self-neglectful, some of whom were still self-neglectful, some of whom had travelled and journeyed through and out of self-neglect. And essentially their message was, it's about relationship, respectful, honest engagement, take time to get to know us, don't push us around too early in the relationship, but be honest about what you're concerned about. Then actually do things that I'm going to find helpful. That's very often practical support, small gifts of a fridge that works, a tabletop fridge, a fire that works, a microwave, objects that can make an individual's life a little bit easier without demanding a lot in return, and that can sometimes travel over the threshold of their property even when you can't. They become a symbol of care, concern, and wanting to assist. And what they were telling us was that through that softly taking time, respectful, honest engagement with some practical support that can be seen to give positive benefits, then you see the building of a relationship, an emotional connection. And it's at that point that with the individual you can possibly plot and plan different options, clearance and cleaning, for example, without needing to go down an imposition route. And they were they spoke very powerfully about the power of relationship that sometimes becomes the intervention in itself. One man said, he's been human, my key worker, that's the best I can say. He has been human, and it's that basic humanity that sometimes makes a difference to people. And one woman, the last quote up at the top right there, this was a woman who in her research interview said, well, I was in a bad way because it didn't really matter what I looked like or what I smelled like because I was unimportant. That's what I felt about myself. When we asked her what had made the difference and what it was about her practitioner, her key worker, she said, well, she got it into my head that I am important, that I am on this earth for a reason. And that really important message about humanity that can change an individual's perception of themselves. Practitioners talk about cocktail, really, what you know, knowledge, professional knowledge, but also knowledge of the individual, who you are, the qualities that you bring, the respect, the curiosity, the empathy, the persistence, the resilience, and then what you do, or sometimes what you don't do, or the timeliness of what you do, the hands-off approach to get to know somebody, but knowing when you have to act decisively because a legal duty requires you to do so. And back to the individual quote who said, well, the only thing that will help is concern. Another human being who can connect with you, who's got a little bit more strength than you. That's what pulls you through. That's what keeps you alive. So, we've taken a tour around the whole system of learning in terms of safeguarding adults, particularly focusing on self-neglect, and we come right back down to the person at the heart. And that's the key message, I think, to take away about all of this. If you would like further resources, on the rest of the slides there are lists of references, things that you might want to follow up. First of all, about safeguarding adults reviews, if you want to read some more about the research, about self-neglect, if you want to read more about the self-neglect research, But importantly, if you have difficulty getting hold of any of that, or if you've got any questions, because it's been tightly timed this afternoon, then please don't hesitate to get in contact with any of us. We're very happy to hear what's happening in practice and to offer any support and help that we can. So, thank you.